My name is Eric Michael Lloyd. I have a master's in psychology, neuropsychology concentration. Today I wanted to read some promising research on CNVs. They relate to various psychiatric diseases or illnesses, conditions, and and yeah, mainly schizophrenia, autism, intellectual disability. Also bipolar disorder, but I'm not going to go into bipolar disorder. CNVs basically stand for copy number variant or copy number variation. And they have to do with the genetic material, your genes, and multiple copies or deletions in some of the alleles, which is what they think is causing the problem with some of these disorders or symptoms of the disorders. For those that don't like to think of them as disorders, how do you say it? Untypical or atypical ways of being, right? So I'm going to go over this little blueprint here. It's the do's and don'ts of helping a family member in psychosis. Number one, don't panic or overreact. When your loved one is experiencing psychosis, he might say or do some strange or even alarming things. The important thing to do is to learn more about what your loved one is experiencing while remaining calm. Milt Greek writes, quote, "People with schizophrenia are emotional sponges," end quote, meaning your family member who is experiencing psychosis can easily be affected by the emotions other people are displaying. So I guess it's more about they're into reading, or somebody experiencing psychosis is into reading the emotions of other people during those times. You may think being in a psychotic state will prevent him from picking up on how you're feeling and acting, but that may not be the case. He may be even more tuned in to negative emotions around him than you are. This is why it is important to monitor your behavior too. Also, don't take anything offensive he says personally or try to confront him about it. It is best to calm yourself before engaging with him. Number two, it says, do listen non-judgmentally. Hear what your loved one is saying and don't dismiss it or laugh it off. Empathize with the emotions he is experiencing. If your loved one is paranoid or acting afraid, understand that he is legitimately feeling fear. So that's, validating the emotion part. Oftentimes, people in psychosis don't readily tell everyone what they are experiencing and why. Ask questions like, what can I do to help? Or, can you tell me more? Keeping a calm tone and making it clear you understand the emotion he is experiencing might allow him to feel comfortable enough to open up. Number three, don't make medication, treatment, or diagnosis the focus. Depending on where you and the family member are in the cycle of discovery, this may not be the first time you've seen your family member in psychosis. You may know the disorder that is causing this behavior and that he is prescribed medication to manage that condition. While that may be the case, informing your family member that he is just experiencing the symptoms of a disorder and that he needs to take more of his medication may only aggravate the situation. It's kind of like downplaying the legitimacy of whatever the person's talking about, whether it be it emotion or fact. The psychosis your loved one is experiencing seems just as real to him as reality seems to you right now. Telling him what he is perceiving isn't actually reality will only drive a wedge between you and him. It's perfectly fine to calmly ask a few questions about medication to gain better understanding of the situation, but insisting or forcing medication while your family member is still in a psychotic state will only lead him to believing you are working against him. You want to make sure your family member thinks of you as being on his team, not an enemy. Number 4, do speak slowly and simply. People in psychosis or who have just come out of a psychotic state might struggle to understand complex language like double entendres, metaphors, exaggeration, or sarcasm. During this time, it's best to speak in short, clear sentences as you don't want to further confuse or upset your loved one. Ask one question at a time and give them enough time to respond. Try to remain at the same eye level as him. If he is sitting, don't stand and hover over him. Also, if others are in the room with you, don't speak about him as if he is not there. You want to communicate to your loved one that everyone is working with him to help him get better. Number 5, don't threaten, especially if you are a parent. It may be second nature for you to threaten a consequence for your child's behavior. When it comes to psychosis, it's not a good idea to issue some form of negative repercussion for his behavior. The motivations for his behavior come from his mental health disorder, not from a lack of discipline. Furthermore, when your family member is in psychosis, try to rationalize him out of his behavior. That his behavior is not going to work. Trying to rationalize him out of his behavior is not going to work. And number 6, do stay positive and encourage help. As mentioned earlier, the emotional turmoil that psychosis brings is very real and often very scary to your family member. It's important to keep your side of the dialogue comfortable and positive. Psychosis may make life seem overly dangerous, dark, and threatening. Your loved one may think there is no escape. Try not to add to this negativity. Ask him, how would you like to be helped? Or, if this has happened before, what has helped you when you felt like this before? He may give you an idea of who he prefers to turn to during this time. For example, he may find his therapist more comforting than his psychiatrist, or vice versa. Knowing who your family member trusts is an important part of finding the right intervention. So this is Schizophrenia, a Blueprint for Recovery. By Milt Greek. This was posted May 12, 2016 on www.rtor.org by Veronique Hobeck. So, on to the topic of discussion. This is a research article from the American Journal of Psychiatry. This actually has the main parts of the background, pretty much anything clinical about CNVs. So it gives me a little bit of background, and I can move on to the recent research by, this was on genengnews.com. So I'm going to read the recent research that basically talks about CNVs and those allele changes in the genome of any person are found more frequently in people with schizophrenia or autism, or people diagnosed with schizophrenia or diagnosed with autism, because I guess that's the right way to say it. And then basically those CNVs, the more CNVs someone has, the more likely, I guess, it's associated with a higher probability of early onset psychosis. So it studied children and looked into early onset psychosis. This is before the age of 18 years old. Psychosis is hearing hallucinations or delusions, I think for at least one day. Psychosis, that's psychotic disorder, so psychosis, psychotic disorder. And then if it lasts a month, then it's like delusional disorder or something. And then if it lasts 6 months, it's schizophrenia, 6 months or more. So delusions, hallucinations, and schizophrenia adds a bunch more negative symptoms. Lack of motivation, anhedonia, there's other ones that I'm not remembering at the moment, but this is more pertinent to psychosis, early onset psychosis in children. The average age that they found that those children were experiencing it, I believe, was 13 years old. So that's very early, and that's probably a very frightening situation for a kid. But what this research shows is that both the parent and the child, the kid, can view this as not their fault. It's just genes. So parenting, I mean, the things that I read there probably do help, the do's and don'ts of helping a family member in psychosis. But at the most fundamental level, the main reason that it's occurring is because of genes. So there's gene editing that many smart scientists are working, and hobbyists, started with hobbyists, are working on changing genes, inserting genes that are connected to benign viruses to cure things such as vision loss, macular degeneration, skin cancers. Kids are being born without the ability to catch HIV. A whole bunch of exciting things are happening with gene editing. So that's the importance, I believe, of CNVs, because I wouldn't want to tell you about a research finding without any foreseeable link in the future to some type of treatment or cure. I don't know how far that away that is. I don't know how close it is. I'm just saying I wouldn't do that at all. So, but it said that 40% of the children studied, it didn't give me much information. You have to go into genengnews.com, and then you have to have a business email. I tried to use my email, it didn't work. I tried to use another email, it didn't work. You have to create a business email. I wasn't going to do that, so I'd rather just read whatever information that they had to provide. genengnews.com. So hopefully they get enough participants that they could give this stuff out to layman people for free. 40% of those people those children had CNVs. Those are children that were autistic. Those are children that were suffering from early onset psychosis, and when they had a control group to compare it to. Not much information that I can glean from it, because once again, I couldn't really download the information or get much from it, even be sent a kit, because they only, once again, allow people with business emails to get a free gene kit. So, whoop-de-doo. The most important finding, I believe, was that the comorbid group, meaning that those that had both early onset psychosis and autism, had the most CNVs, right? It was the most significant finding. Now, the other two groups, it washed out. So, meaning those that had early onset psychosis and those that had autism probably have roughly equal numbers of percentages of CNVs, which are copy number variants, okay? But the ones that had the most probably are suffering the most distress. And those that had the most were those that had early onset psychosis and autism. So they had significantly more CNVs than either the comparable amounts between the children with autism and the children with psychosis. Okay, so it's probably really tough on those that have both. Once again, parents aren't to blame. It's not your fault. And I'd also say, like I did before, it's neither the kid's fault. Now I'm going to move on to an article from the American Journal of Psychiatry. I'm going to read a little bit, and then I'm going to go into one treatment that I found. I'm just going to read the treatment. I'm not going to say that I'm recommending this or not. I'm just going to read it as is, and you talk to your doctors. You determine safety, and if it works, it's effective for you. Increasing the clinical psychiatric knowledge base about pathogenic copy number variation. Patrick Sullivan, MD, Franz CP, I don't know what that is, and Michael J. Owen, MB, CHB, PhD, and FRC Psych. So this article was published in the American Journal of Psychiatry in 2020, March 1st. So it's just going to give me a little bit of background. And I say background because this research article from genengnews.com, or that was referenced on genengnews.com, is the newest information that I can find, the newest findings on gene editing and copy number variation and its relationship to psychiatric diseases. This is some background stuff. As I said, it's 2020. Abstract. Specific copy number variants have been robustly associated with intellectual disability, autism, and schizophrenia. Most of the literature focus has been on documenting the existence of these phenomena. There are a few data to guide therapeutic choices for these orphan diseases. We call for systematic and longitudinal case reports which, if carefully conducted, may provide crucial initial knowledge to guide therapeutics. We provide a step-by-step overview, a tailored set of consensus criteria for high-quality case reports, and a specific set of learning resources. Plain language summary. Copy number variance increases or decreases in the inherited quote-unquote dosages or one or more, I would say of one or more important genes. I think that's a typo. Are increasingly recognized in clinical psychiatry. We call for a clinical crowdsourcing for more systematic case reports to help clinicians identify sound treatment options. Imagine an initial psychiatric interview that begins with the chief complaint. I have de novo 16p11 duplication, and they say I have schizophrenia and Asperger's. What does this mean for me and my family? Well, Asperger's no longer exists. They subsumed that into the autistic spectrum. But anyway, what does this mean for me and my family? How can you help me? Provided that the patient's report can be verified, this chief complaint has a strong scientific empirical basis. As the patient says, this, quote, copy number variant, or CNV, results in changes in the number of genes of 30 genes located on a 600,000 base pair region on the short arm of chromosome 16. And this rare genetic mutation increases risk for autism and schizophrenia. As a supplemental note 1 to also review that reference. How exactly would you help? What evidence would you support your clinical choices? Would you use to support your clinical choices? On the basis of current knowledge, a clinician should explore the possibility of other psychiatric diagnoses, major depression and speech and language delay, and be alert for the presence of physical abnormalities, including renal and urinary malformations, as well as consider the need for genetic counseling. Right, that makes sense. Major depression and schizophrenia, and which could be comorbid. It could be one primary disorder, and then one that's kind of like a subset that's more transient, meaning the person has major depressive disorder with psychotic features instead of actually psychosis or schizophrenia. So that should be checked. And then since they said Asperger's, then you would also want to check for language delay, which is correct. And be alert for presence of physical abnormalities, including renal and urinary malformations, as well as consider the need for genetic counseling. So I would understand genetic counseling, but renal and urinary malformations, I'm not sure why they would be checking. Well, I'm not sure if they're checking the genes or if they're checking the function. I don't know, or the metabolites maybe. That's probably what they're doing, but that would also go into genetic counseling. So maybe that's redundant. However, while there may be broad implications for the broader implications for the patient and their family, to the best of our knowledge, there are few relevant data that inform the psychiatric management of this patient. Thus, how can our field cooperate in order to rapidly increase knowledge relevant to clinical management? Although this scenario might seem far-fetched, genetic evaluations are increasingly part of standard care in psychiatry. A genetic workup is increasingly part of the clinical evaluation of children with moderate to severe intellectual disability. Right, you would also want to check for this. Marked developmental delay and autism, and is justifiable for adults who present similarly or who have complex presentation. See below. In fact, psychiatrists who treat individuals with there's a lot of typos in here. Wow. In fact, psychiatrists who treat individuals with psychiatric disorders, including ourselves, are certain to have encountered patients with important genetic changes, and we probably did not know it. The rapid pace of progress in medical genomics means that these topics and their implications will be unfamiliar to many clinicians, and a number of educational resources are available. It has the supplemental material there, so those are the educational resources in Table S1. Normally, children inherit a parental and maternal copy of every autosome, chromosomes 1 through 22. Occasionally, there are errors in the meiotic or mitotic machinery, so that large regions, often containing multiple genes, are lost or gained. Such changes are termed CNVs. So large regions containing multiple genes are lost or gained. Such changes are termed CNVs. These can occur at the level of the whole chromosome, like trisomy 21, 48.1 megabases, or at finer levels, hundreds of kilobases or smaller, as with 16p11 CNV. That's foreign language to me. Many pathogenic CNVs recur due to regional genomic features and can be found worldwide. Has supplemental material there. You can click on that. For that citation there for worldwide genomic features of CNVs. Genomic studies have established the etiological importance of specific CNVs for psychiatric outcomes, with most of these CNVs associated with variable outcomes, pleiotopy, including moderate severe intellectual disability, developmental delay, autism, tics, discoordination, and schizophrenia. There's a figure there. You can look as well for. In samples seen in clinical psychiatry, current estimates suggest that a clinically or etiologically relevant CNV is likely to be present in around 2 to 3% of people with schizophrenia, 10% of people with autism, and 25% or more of people with intellectual disability. Now, remember in that last research I talked about the higher prevalence of CNVs, the significantly higher prevalence of CNVs in people with both early onset psychosis, that's before the age of 18, and autism. So imagine what those kids gotta go through. Imagine what their distress level is. In general, the greater the severity, the higher the prevalence. So i.e., lesser in unselected population surveys and higher in the most severely ill. So, yeah, like I was saying, it's an association. The more of them, in general, the greater the severity, the higher the prevalence of CNVs. So, more likely to have them. Or have more of them. The accumulation of disease-relevant genomic data begs the question of how this should impact on clinical decision-making, but the clinical knowledge base is limited. We need more treatment and management data to guide therapeutic choices for people with pathogenic CNV and severe psychiatric disorder, and to be able to address questions about familial risk. It's a genetic disorder. Although the associations of specific CNVs as etiological risk factors are secure, we do not now have an adequate knowledge base to inform the practice of clinical psychiatry. In almost all instances, the emphasis is on diagnostic features, unusual presentations, and information particularly salient to clinical geneticists, neurologists, and pediatricians. In reviewing the literature, we found that the clinical knowledge base relevant to psychiatric management is sparse. There are few data relevant to the question in the first paragraph. How can you help me? Sparse. There's a lot of typos in here. I don't understand how this is an NIH.gov article. No one edited this. Although, as a group, these CNVs are not uncommon, or a not uncommon etiological risk factor. The individual CNVs are rare, and almost all are orphan diseases, meaning impacting under 200,000 people in the U.S., the lifetime prevalence, which is less than 0.06%. It's almost triple the amount of people projected to die from the coronavirus, right? Accruing sizable samples for seismic study requires international consortia, considerable expense and many years of effort. So, I mean, why wouldn't they put forth the same fervor that they did for the coronavirus, for CNVs and psychosis research, and what actually isn't psychosis, I would say, right? Or schizophrenia. Distinguishing that. Accruing sizable samples for a systematic study requires international consortia, I read that, considerable expense, and many years of effort. A prime example is the international 22q11.2 deletion syndrome. Okay, 22q11DS is is the abbreviation. Brain Behavior Consortium is the supplemental reference. This consortium has assembled a sample of 1,616 psychiatrically well-characterized cases and obtained genomic data on greater than 300 adults, split evenly into those with schizophrenia and those without. I like how they did that, split evenly, split brain disorder. The aims of this study are to understand how other genetic and non-genetic factors influence the expression of schizophrenia that may be of wider relevance to the general population, and to provide information on the precursors and antecedents of schizophrenia, and to serve as a base for future longitudinal studies aiming to study the neurodevelopmental trajectories of deletion carriers. All right, so basically I want to know everything about it. What comes before it, what causes it, what's the trajectory of somebody with these CNVs, what they can do to help. They want to know everything about it, pretty much. The outcomes of the study are beginning to appear and include the largest characterization of psychiatric outcomes in 22q11DS, that's deletion syndrome, to date, and identification of childhood antecedents of psychotic outcomes. So basically, what factors or circumstances in childhood that come just before the psychotic breaks, right? Psychotic outcomes, psychosis. Because if you know what comes before, then maybe you could do something to help, to mitigate it, to reduce it, to prevent it, to stop it, or to treat it, right? It is reasonable to ask whether improved therapeutics are likely, or how to plan to manage it in the family, right? Work or school. Intimate relationships, things like that. We do not know. However, as a proof of concept, Deborah Levy and colleagues recently reported 2 individuals with psychotic disorders and very rare CNV triplications of the glycine decarboxylase gene. Under the assumption of NMDA hypofunction due to increased glycine catabolism and low levels of brain glycine and D-serin, they demonstrated clinical improvement in psychotic and mood symptoms with oral glycine supplementation, double-blind, placebo-controlled. Oh, that's interesting. I have my own bottle of glycine myself, because I'm a gym rat who likes to take protein in all my supplements, and I've grown quite fond of the supplements and what they could do for brain boosting or muscle recovery. So you gotta love those essential amino acids. They demonstrated clinical improvement in psychotic and mood symptoms with oral glycine supplementation, double-blind, placebo-controlled. If a clinician were to encounter a patient with this CNV in the future, this report would provide reasonable therapeutic guidance. We propose a systematic effort to obtain clinical data useful to management in clinical psychiatry. We effectively propose clinical crowdsourcing that combines the advantages of a distributed effort with a comprehensive and systematic structure in order to yield high-quality case report and case series knowledge to inform clinical psychiatric management. Our proposal has the following steps. Detection. So they're going to they go into what they use to detect, what clinicians should use to detect, or what they propose in their research when they use to detect CNVs, to capture the needed data that they want. Publishing the case report, benefits and challenges, so it goes up to page 14, right, 36 minutes. I'll keep going. All right, so this is the systematic effort that they propose to obtain the clinical data that's useful in management in clinical psychiatry, all right? So, number one, detection. We need to test more patients for CNVs. In fact, there's a strong case for universal testing for some psychiatric disorders, particularly early onset and severely impairing conditions, moderate, severe intellectual disability, and autism, as well as chronic psychotic disorders in adults. A positive result is relevant to clinical management. Most large CNVs are multi-system disorders with increased risk of cardiac, neurological, endocrine, renal, and hematological and digestive complications. There was no and before hematological. We encountered a patient whose idiopathic thrombocytopenia was chased after for years, but was almost certainly a consequence of 22q11ds. We know of drug companies working on therapeutics for specific CNVs. If targeted medications become available in the future, we need to know the patients for whom these therapies may be indicated. The presence of a CNV can be relevant to reproductive planning, but the wide range of psychiatric and cognitive outcomes and incomplete penetrance calls for nuanced and informed genetic counseling. CNV testing is typically offered for children with ID, developmental delay, or neurodevelopmental disorders, but CNVs are also risk factors for adult psychiatric cases, particularly schizophrenia. What clinical features increase the likelihood of the presence of a CNV and should act as flags or targeted testing in adult psychiatry? We are not aware of systematic studies, and there is clearly a pressing need for these, as we argue below. However, based on current knowledge, we would highlight premorbid low intelligence, a history of childhood onset neurodevelopmental disorder, congenital malformations, dysmorphic features, and developmental delay, missing developmental milestones. A family history of schizophrenia or neurodevelopmental disorders may also be relevant. Also, pathogenic CNVs frequently occur de novo, and so a family history of a parent is often absent. Finally, we never discount the importance of the intuition of experienced clinicians, or the sense that a particular patient is distinctively different from others in the same diagnostic category. Examples here include severe symptoms or extreme treatment refractoriness and prominent physical comorbidity. Exactly what test to order depends on the clinical context and on the availability and cost of technologies. We offer the Excuse me. Following general considerations. It is past my bedtime, but I'm going to get through this. If it kills you, that's a joke. First, consultation with a clinical geneticist and or genetic counselor may be helpful. Second, for adult psychotic disorders, evaluation of CNVs would be a typical starting point. One technology for this purpose are chromosomal microarrays, CMA, which can identify the presence of large pathogenic CNVs, copy number variants. Cost approximately US $300. Third, for early onset, severe psychiatric disorders, a typical panel would include CMA and resequencing of the protein coding portion of the genome, whole exome sequencing, or whole genome sequencing, applying the same technologies to both biological parents. Can help in prioritizing detected variants and in determining whether a variant is de novo or inherited. So, did the offspring get it themselves, or is it from the parents? Pretty much, right? Number 2, capture the needed data. In most instances, case reports that only describe the co-occurrence of a known CNV with a psychiatric disorder may not be particularly notable for associations that have been extensively documented. At the same time, there may be some novel or more remarkable feature that would support publication. Example, our report of a man with 22q11ds and Huntington's disease. In our opinion, we need case reports and case series that have 2 key features: a comprehensive initial assessment, and B, a systematic description of longitudinal course and the impact of therapeutic efforts. So I guess they're saying that some case studies are, may not, not all case studies are made the same, right? They basically need something that's very thorough the whole way through. What's the initial assessment? How thorough was it? Was it really good? Did they test everything under the sun? And then did they describe the longitudinal course and each therapy, and if it worked or not? It seems like pretty much everything to me. Initial assessment should include a multi-informant history of salient events in pregnancy, birth, childhood development, adolescent, and adulthood. Wow, that's pretty extensive. Multi-informant history, pregnancy, birth, childhood development. Wow, yikes. I could see childhood development, maybe adolescence, adulthood, maybe, but pregnancy and birth, I don't know. What if the parents don't have the same friends, or maybe, I don't know. You can look at reports and stuff from doctors, I guess. Ask the neighbors. Assessments or indications of schools, churches. Assessments or indications of intellectual function, or those ex-boyfriends, right? Assessment or indications of intellectual function across development are very important if not essential. Collecting such data from a psychiatric perspective is generally routine in clinical practice. However, for CNVs, there should be particular attention to congenital and multi-system abnormalities across all organ systems. Multi-system abnormalities across all organ systems? It's the only part I'm not really getting. Intellectual function, I get. You got to get that information. Psychiatric information, parent, kid, I understand that. Congenital and multi-system abnormalities. Okay, across all organ systems. How much data do they expect parents to have? I don't know. The presence of physical comorbidities should be sought, perhaps in collaboration with medical colleagues from other relevant specialties, bearing in mind those conditions known to be associated with a specific CNV. So any comorbidities, like the ones stated before, perhaps in collaboration with medical colleagues from other relevant specialties, bearing in mind those conditions known to be associated with a specific CNV, which one that they did not include was bipolar disorder. Finally, a thorough family history should be obtained with a focus on the range of neurodevelopmental disorders, including schizophrenia, that are associated with risk CNVs. Many would suggest that brain imaging using MRI is important. The critical missing ingredient is the longitudinal course and impact of therapies. There needs to be a systematic description of age-dated therapeutics across all modalities, pharmacological as well as behavioral and psychological. These need also to be connected to age-dated assessments of functional capacity, occupation, role function, and inpatient, emergency, and outpatient treatment. Combining these data are needed to establish correlations as to what therapeutic strategies were optimal for this particular patient. In effect, a variant on the N of 1 clinical study. We note that modern data science has many excellent and free tools for obtaining, refining, summarizing, and presenting complex longitudinal data. This is increasingly easy to accomplish given the availability of electronic records. This thing needs to be edited. For example, figure 2, which you can click on, took 5 minutes to make, but captures 25 years of pharmacotherapy for a person with highly treatment-resistant psychosis. So it's an illustration of graphical methods to succinctly portray a complex pattern of pharmacotherapy over 25 years. Using an electronic pharmacy record, the dosage of each psychiatric medicine per week was tabulated. The x-axis is age, with each year comprising, and it goes on and on. So, over 25 years, what medicine was administered and correlated with all the other data, like if they went to the emergency room, outpatient treatment, what worked, what didn't work, and to what degree, how much were they able to function in life. Publish a case report. It is then important to let the scientific community know what you've learned. The particular focus should be on what worked, what did not work, and what you might do differently if you could do it over. We strongly advocate for following explicit guidelines for the structure and content of a case report. For instance, the CARE criteria, which were developed in the general medical context to improve completeness and transparency and facilitate the systematic aggregation of information across reports. You can click on the link there, 13, table S3. In particular, the title should include case report and standard terms for specific genetic change and the psychiatric diagnosis. Reasonable examples of CNV case reports series may be found in these references, 10 and 14. There, you can click on it. There are multiple target journals for these case reports. Particularly detailed or notable case reports may appear in higher profile journals. However, it is critical for these case reports to be findable via inclusion in searchable resources like PubMed and PubMed Central. There are multiple open access journals devoted to case reports and indexed in PubMed. A basic web search for case report journals found 10, and there are even overviews on the choice of case report journal. Okay, so it has to be some systematic method to which you complete the case report. If you're a clinician, they say that you should use the CARE criteria. It helps to tabulate and develop correlations, and helps with the main point of research, which is to have some sort of association so you can, and replicability of treatment findings. So if everyone, let's say, speaks the same language, you get things done faster, for example, right? That's an example. I like different languages. I actually have studied different languages. I'm not great, but I have. But it makes things easier, it makes things simple, and then you can compare things easier. So if one person completes a research study one way, and then another person completes a research study on the same topic in a completely different way, you can't compare those two things together. So you're comparing apples to oranges, and both strategies might work, but the researchers are going to continue to say there's contradictory findings, or there's non-replicable findings and little evidence base, when in all actuality, both may be valid, true, accurate, but they just did them two different ways. So it's better to have replicability for people to build an evidence base, for researchers to have basically the confidence to tell people that it works. That's the whole thing about research and evidence-based in science. So yeah, something may work and something may actually be valid, but if they can't replicate it because people do it in different ways, in different methods, then it's you can't. It's going to suffer lack of funding. It's going to suffer lack of awareness, lack of support, and the treatments that work, whether they work or not, probably won't get to everybody that it can get to. That's just, I don't know. I think this could be a flaw in research. I don't know. Like, if somebody did one test one day and it works, and somebody does another type of test another day and it also works, then so what? Those both worked. But we just can't say, oh, you know, it's studied as heavily as like some physical phenomenon that everyone studies, like jackrabbits. But we can still say that it works. But you just can't say that it's widely distributable to everybody. We can't say that it's going to work on this person, that person, this type of person, that type of person. No matter what their demographics are, no matter the time of year, it limits our ability to say that it will work for everyone at any particular point in time. It's just the way it is. Benefits and challenges, that's number 4. The potential benefits of what we propose are to allow other clinicians to benefit from the experiences of colleagues in the struggle to deliver effective clinical management and identify treatment options for individuals with rare pathogenic CNVs and severe mental illness. Many patients with CNVs experience protracted and stressful diagnostic odysseys and referrals to multiple specialists for organ-specific evaluations when, in the end, the root cause is a CNV with impacts on multiple systems. Minimizing time to CNV identification would minimize such odysseys and rapidly signpost potentially appropriate non-psychiatric assessments. Moreover, it is possible that detailed evaluation of these rare patients could yield therapeutic and etiological ideas relevant to patients with idiopathic forms of these disorders. Bespoke therapeutics may ultimately, quote unquote, may ultimately be an important benefit. For certain rare CNVs, the literature may suggest a therapy that is uniquely tailored to an individual with a particular CNV. Current examples include the use of oral glycine in CNV triplications, the glycine triplications of glycine decarboxylase of the decarboxylase gene, and the anecdotal use of oral magnesium supplementation in Burnside-Butler syndrome, 15q11.2 CNV deletion that impacts NIPA1 and NIPA2, which are involved in brain magnesium transport. We contend that by rapidly sharing and disseminating clinical and therapeutic findings, we may be able to build on these small but important beginnings. A focus on copy number variation, I almost forgot the name there. It's such a weird thing to say, copy number variation. A focus on copy number variation can also improve diagnostic classification. Copy number variation. You know, I've never heard of a copy number when it comes to genes. Has anybody heard of that? Studying biology? Copy number? Copy number. Who came up with that name? It's a terrible name. Many CNVs have highly variable clinical presentations that can include combinations of intellectual disability, specific learning impairments, autism, ADHD, anxiety, mood disorders, and psychotic disorders. Okay? And so we now got two more. We got ADHD, anxiety, mood, learning impairments. In current diagnostic schemas, these are coded according to the clinical presentation. However, while this has value, it is crudely akin to coding rash, fever, headache, photophobia, and altered mental status instead of meningitis, which is meningitis. Given the range psychiatric disorders and medical comorbidities associated with these copy number variants, a primary diagnosis that includes reference to the CNV may be more parsimonious and to capture and to alert clinicians to the full range of important sequelae. These are coded according to categorization. Okay, yeah, so this is just about how to code it diagnostically. Why don't they just draw a map and see whatever it's associated to, and figure it out from there. I mean, it's a map. So if you draw like a map or a diagram, you could see it better. We primarily learn with our eyes, and you draw things out. You could kind of figure it out a little bit better. Yeah, figure out how it works best, how it makes sense best. Several challenges are noted above, particularly the greater need for longitudinal and process outcome data, as opposed to merely documenting the co-occurrence of a CNV and a clinical presentation. Okay, so not only the CNV, clinical presentation, but also the outcome, the process outcome data should be noted, right? An additional challenge is that advances in psychiatric and medical genetics mean that psychiatrists, particularly those in training, will need to understand how to generate, interpret, and explain genetic findings to their patients, as well as how to use data clinically. There are multiple ways to obtain direct-to-consumer genomics, many of dubious clinical utility, and clinicians will increasingly be faced with questions about their relevance. Doctor, why am I getting these tests again? How is this relevant? There are multiple ways to obtain direct-to-consumer genomics, many of dubious clinical utility, and clinicians will increasingly be faced with questions about their relevance. Doctor, why is this relevant? I know I just read that, but why is this relevant? I'm suspicious. Is this fraud? Are you going to send me to the gallows? And clinicians will increasingly be faced with questions about their relevance. For interested readers, Table S1, which I continue to not look at, contains a list of learning resources. So you can learn about how to, all about it. There is clearly a need to embed genetics training. It says embed genetics training deeply in residency training programs and to upskill practicing psychiatrists. Okay. Nuremberg et al. Provide recommendations for psychiatry residency training and note, quote, the basic principles of genetics are essential to current psychiatric patient care. I encourage anyone and everyone to learn about this stuff, not psychiatrists or anyone else, or you don't have to go to medical school. Learn about it on your own. If you're interested enough, you can learn anything. Listening to Ben Shapiro in his podcast in the background has inspired me to realize that if you're interested and motivated enough, you can do anything, college or not. You have a brain works the same way, no matter what. Experience is the greatest teacher. I'm not saying to go mix up a bunch of gene editing tools and try to cure your dog and your cat. I'm not saying not to. I'm just telling you that people can learn this stuff on their own, and they have. They've also messed up. I don't know about horror stories, but I know that the tools that people use to genetically snip and edit certain genes using CRISPR, a gene editing tool, has significantly improved since 2001, where a kid died because they had the snipper of whatever gene or allele. I'm not laughing at the kid dying. The snipper of the gene or allele that was malfunctioning, and it went inside the cell and snipped the wrong area, snipped the wrong part of the genome, and the kid had developed cancer or something like that. Now it's not like that. With CRISPR, it's exact. Wherever area that you program, I say program because it's just that they use, RNA to find and locate, but I'll call it programming. They use CRISPR with RNA to find a defective allele and snip it where it's supposed to be snipped, and replace it with a non-defective allele variant, so that the person can now see or doesn't have a blood cancer problem or skin cancer or something to that effect, right? That's CRISPR and gene editing. And this relates to it because CNVs are copy number variants, which are deletions or copies of alleles and genes at different levels, whether it's the whole chromosome or whether it's a small part of an allele of a chromosome. Right, okay, so there, for interested readers, you could read there, table S1. There is clearly a need to embed genetics. I read that already. A key challenge is clinical synthesis. For the patient introduced at the start of this article, how would a clinician efficiently, effectively, and accurately extract clinical guidance from the literature? Effectively, efficiently, and accurately extract clinical guidance from the literature. Literature reviews are usually a great starting point, if they exist, but with the caveat that they miss case reports since submission. Now, I could say that probably they could do this effectively and accurately, but efficiently, I don't know. You probably have to read a little bit of literature before. That's just my guess. You kind of muddle around a little bit until you find your way to what you want to do. I think that's usually with anything. Oh, I'm a genius. Everything I've ever started, I do completely well the very first time, efficiently as possible. I'm a robot. Literature reviews are usually a great starting point, if they exist, but with the caveat that they miss case reports since submission. Moreover, they may not cover the exact clinical need. So literature reviews may miss case reports. They may not cover the exact clinical need. We suggest there is an unmet need. We need a structured and curated online database that captures case report data at the interface of genetics and clinical psychiatry. This is largely informatics, but requires a funder to champion and support the idea. The idea is straightforward: to systematically capture the genetic mutation, the clinical phenotypes, that's what the genes express. So the genes may have something going on, but then it's whatever is expressed from the genes that have something going on. That's the main important part, the phenotypic expression of the gene. The phenotype, clinical phenotypes using a structured vocabulary, right? You got to capture that too. For example, the human phenotype ontology, therapeutics attempted, and the therapeutic outcomes and adverse events. So all of that has to be online so that they can create an online database to map what genes are doing what, when, and what therapies are being used, and what's working for what, and how it's working in relation to genes and the therapy. All online. and adverse events, right? So a reasonable model for this is Decipher, is the Decipher database in the UK, the United Kingdom. It has a link to it there. In addition, such a database could serve as the basis for research and grant applications to derive clinical and biological hypotheses, as well as to support accrual of orphan patients for future systematic studies. Okay, so you can use that database for hypotheses and orphan patients. I'm not quite sure what orphan patients are, but you can adopt a patient for a study. Language on that's just a little removed from the human experience. The existence of a sizable body of cases reports, particularly if prepared to a high standard, would provide practical guidance for the clinical psychiatric management of people with a psychiatric disorder and a pathogenic copy number variant, CNV. If we were to have 10 such reports for the vignette at the start of this essay for a de novo 16p11 CNV, schizophrenia, and Asperger's, how can you help me? This could synthesize the reports to derive an empirical management plan. You might also discover a psychiatric colleague with particular expertise in treating people with 16p11 CNVs in adult patients, and a conversation or email exchange could be helpful. So the more examples you have, right, the better able you're to come up with a management plan, empirical management plan, find the right expert for the particular, identify what's going on, what type of CNV is affecting each patient and why. What specific type of CNV, and then you can find an expert with that particular type and touch bases with them, right, to help the patient and to help the literature, the research, to better solve the problem. Better case report data are literally better than nothing. However, ultimately, there is a need for more adequately powered studies that are able to relate scientific genomic risk factors to clinical and neurocognitive outcomes in therapeutics. The individual CNVs are rare, but the clinical psychiatric phenotypes with which they are associated are not. And the variable expressivity and pleiopatry seen offer an important opportunity to investigate the role of other genetic and environmental factors in modifying psychiatric outcomes and to deliver findings of relevance to psychiatric disorders more generally. They also offer an opportunity for studying groups of subjects in early childhood at risk of later childhood and adult disorders, and of studying the developmental course of psychiatric disorders and identifying potentially modifiable antecedents and modifiers. Whew! So, run-on sentence, huh? It is gratifying that NIMH, National Institute of Mental Health, has identified the potential of these studies and the need to assemble coordinated multidisciplinary and multi-site teams capable of combining genomic data with comprehensive dimensional and categorical phenomena data. This is an excellent beginning, but we believe that more attention, funding to this emerging area is required. So, interesting work. It acknowledges the Swedish Research Council, the U.S. National Institute of Health, Mental Health. They acknowledge the Wellcome Trust Strategic Award, a Medical Research Council Center grant, and you can read a lot. You can read the rest there about the European Union and different things like that. So that's that. So what I'm going to read here is from academic.oup.com. Let's see here. Push through. Schizophrenia Bulletin Open, MPRC. MPRC stands for Maryland Psychiatric Research Center. They have a FPRC, Florida Psychiatric Research Center. My Genius Inc. But anyway, journal article, Understanding the Potential Benefits of Cannabidiol for Patients with Schizophrenia, a narrative review. This was written by Garrison JB Dyck, Zaid H Maayah, Dean T Eurich, and Jason R B Dyck. Schizophrenia Bulletin Open, Volume 3, Issue 1, January of 2022, SGA B053. I don't know what that is. And it has the link, the hyperlink there. Abstract. Research suggests that cannabis-derived delta-9 tetrahydrocannabinol can be linked to the worsening of psychosis and or other symptoms of schizophrenia. However, studies have shown that another major cannabinoid found in cannabis, cannabidiol, CBD, may be a potential alternative or adjunctive treatment. So both and treatment for psychosis and schizophrenia. As such, herein we review the relevant literature referring to the safety and efficacy of CBD treatment in patients with schizophrenia, including the effects of CBD in treating the positive, that's anything added that typically normally people don't have, like hallucinations or delusions, false beliefs or false perceptions, whether they be auditory, visual, tactile, feeling things that aren't there, and cognitive symptoms of the disorder, okay, thought disorders, right? People are after you, people are in love with you. What else do you got here? People want to harm you in some way. People are persecuting you, and these are only obviously in the cases where that actually is not happening, right? I would say, yeah. It is actually happening then. Run, hide, fight. Right? It's a joke. Stay safe. And cognitive symptoms, as well as the molecular mechanisms by which CBD can reduce schizophrenia symptoms. The potential utility of CBD for mitigating cannabis cravings and cannabis withdrawal in this patient population will also be reviewed. Lastly, the dosing, method of drug delivery, length of treatment, and adverse effects of CBD in patients with schizophrenia are discussed. Thus, the goal of this narrative review is to help clinicians and researchers better understand the risks and benefits of this potential therapy for this patient population. Fumble through this. Multiple studies support the conclusion that cannabis use is associated with the development of psychosis and schizophrenia. For example, a robust longitudinal study in Sweden found that adolescent cannabis users had 2.4 higher chance of receiving a diagnosis of schizophrenia than those who had not used cannabis in adolescence. Similar studies have also shown a compelling link between cannabis use and the development of schizophrenia. Furthermore, the overwhelming majority of studies that interrogate the specific actions of individual cannabinoids suggest that delta-9 tetrahydrocannabinol, THC, is the main component of cannabis responsible for any worsening of psychosis and other symptoms of schizophrenia. With that being said, it is important to acknowledge that cannabis is a complex plant with hundreds of other active compounds, some of which may have opposite effects to THC in patients with schizophrenia. Indeed, evidence suggests that certain cannabinoids, such as cannabidiol, CBD, are potentially beneficial in the treatment of schizophrenia, and thus may be an alternative or adjunctive therapy for this patient population. Moreover, CBD may also have an advantage over existing treatments, as CBD is associated with fewer side effects than currently used dopaminergic antipsychotics. Thus, given the potential benefits of CBD in schizophrenia, a better understanding of this molecule is warranted. I have my own theories as to why THC might be linked with a 2.4 higher chance, but if it's not backed by the mechanistic biological mechanisms, then I'll just keep that to myself. Previous research provides a substantial amount of information about the beneficial effects of CBD for the treatment of patients with psychosis and or schizophrenia. However, some of these reviews focused on discussing selected clinical studies on the basis of statistical analysis. In addition, others reviewed a possible role of CBD for treating addiction, cognitive dysfunction, and psychosis related to substance, like cannabis use disorders, or neurodegenerative disorders. To expand on these reviews, we have chosen to provide an update on the most recent advances made in the field, including a review of the evidence for the utility of CBD in treating the positive, negative, and cognitive symptoms of schizophrenia, as well as for treating cannabis cravings and cannabis withdrawal in patients with schizophrenia and a co-occurring cannabis use disorder and or cannabis dependence. We will also include an up-to-date discussion of dose, method of drug delivery, length of treatment, and adverse effects of CBD, as well as the molecular mechanisms by which CBD can reduce schizophrenic symptoms. Thus, the goals of this narrative review are to, number one, comprehensively examine the current evidence regarding the effects of CBD in clinical studies involving patients with schizophrenia. Number two, discuss how this evidence may foster future research on compounds like CBD that have the potential to provide improved treatment and quality of life to those with the disorder. Sounds like some fun stuff, huh? Overview of CBD. In 1940, CBD was the first identified non-psychoactive cannabinoid in hemp. First one. and was then subsequently shown to be a non-psychoactive component of cannabis sativa. Since then, CBD has been found to possess multiple pharmacological actions such as analgesic, anti-inflammatory, anticonvulsant, and antioxidant effects without causing the typical adverse effects of THC. Of interest, the pharmacological effect of CBD seems to be mediated via cannabinoid receptor independent mechanism, a cannabinoid receptor independent mechanism, such as activation of 5-hydroxytryptamine 1A, it's 5-HT1A receptor, or suppression of a G protein coupled receptor 55, GPR55. Moreover, based on clinical trials involving CBD-rich extracts, the FDA recently approved CBD for the management of treatment-resistant epilepsy such as Lennox-Gastaut syndrome and Dravet syndrome, indicating its safety and efficacy in this patient population. This recent advancement has not only demonstrated that CBD has the potential to therapeutically alter brain activity, but it has also paved the way for considerations of CBD for the treatment of other neurological and mental health disorders such as schizophrenia. Methods. The literature review for English articles from 1970 to 2020 was conducted using PubMed, clinicaltrials.gov, and Google Scholar. Studies involving the use of CBD as intervention for schizophrenia and psychosis were selected using the terms Cannabidiol, CBD, schizophrenia, psychosis, and psychotic symptoms. Summary of findings. Clinical evidence of the potential benefit of CBD in the treatment of schizophrenia. The efficacy of CBD as a therapy for treatment of symptoms associated with schizophrenia was first reported in a clinical trial published in 2012. This randomized, double-blind, parallel group, active controlled study demonstrated the therapeutic effect of CBD as a monotherapy in the treatment of schizophrenia using the positive and negative syndrome scale. It's called PANS. I like to think of it as PANSY. And brief psychiatric rating scale, BPRS, to assess patient-reported changes in the progression of schizophrenia from baseline. In total, 39 patients with schizophrenia received either 800 milligrams per day of oral gelatin capsule of CBD, N was equal to 19, or the standard antipsychotic amisulpride, N is equal to 20, for 4 weeks. Notably, patients receiving CBD or amisulpride showed a statistically significant reduction of PANS and BPRs for positive and negative symptoms of schizophrenia over the baseline. So that's promising. 4 weeks of either treatment, the CBD or the, what's it called again? Amisulpride showed reduction, statistically significant reduction. That's what you want to look for, statistically significant reduction. It's like, okay, how much did you grow from last summer to this summer? I grew a little bit. Like, how much? Like, from here to here, it's like 1 millimeter? Or did you grow like Michael Jordan, like a foot? That's called statistically significant. So positive and negative. Positive is the symptoms that normally aren't there that are added, like delusions, hallucinations, and negative symptoms are things that are normally there within people that is removed, like lack of motivation, anhedonia, what's it? The other one is speech. I believe there's problems with speech, things like that. Negative symptoms, motivation, probably movement. It also involves movement. Movement disorders like staying in cataplexy, staying in one position, or waxy flexibility, which is kind of odd positioning of the body and staying in that position for very long periods of time. Catatonia, zombie-like state where the person's not responsive to anything, not moving. These are things that are removed from the person, right? Those are not positive symptoms. Those are negative symptoms. Normally the person's lively. Normally the person has motivation to do things. Normally the person is talkative. Normally the person, can function, and those are removed from the person. So those are negative symptoms. Positive symptoms are things that are added to a normal person's experience, like adding false beliefs, adding false perceptions, could be auditory, tactile, like feeling spiders are on you or something like that all the time, like, or a lot, not just like you're running and something brushes you and you think it's a spider. It's not like that. It's a much more severe kind of presentation, and then anything added visually, right, to your perception that's not really there, or hearing things that aren't really there either. So that's auditory. So those are positive symptoms. And then the other ones described were negative symptoms, things that are normally there in a person that are taken away. It helped both of those. That's the amisulpride and the CBD, right? Statistically significant reduction in those measures that measured the positive and negative symptoms in schizophrenia over baseline. So over baseline is over the start of the study to 4 weeks later, comparing those two. Of importance, the improvement in psychotic symptoms observed in CBD patients was similar to those who received amisulpride, suggesting that CBD is a promising candidate for the treatment of schizophrenia with comparable efficacy to the standard treatment. Interestingly, although the treatment with amisulpride was associated with typical side effects of antipsychotic drugs, including motor disturbance, extrapyramidal symptoms, higher serum level of prolactin, and weight gain, CBD was well tolerated, and none of the aforementioned adverse events were reported in patients administered CBD. Okay. Oh, interesting. Similar side effects, but none of the aforementioned adverse events were reported. Wow, so that seems like the case for CBD over amisulpride, isn't it? No adverse events, yay, haha. Thus, these findings suggest that CBD has a more favorable safety profile than amisulpride, and provide evidence that CBD is equally efficacious as amisulpride for patients with schizophrenia. Equally, I'd say that's better. Using my sound mind, I would say that's better. I wouldn't say that's equal. Given the fact that, like I said, not all pharmaceuticals are created equal. Given the fact that, number one, at least 80% of people with schizophrenia suffer from cognitive impairment, and number two, the standard antipsychotic therapies have limited effects on cognitive performance in patients with schizophrenia, identifying new antipsychotic agents that can help reduce cognitive impairment associated with schizophrenia is extremely important. So not only are we getting into the reduction of the positive and negative symptoms and no adverse events, now we're getting into actual proliferation of the person's cognition, cognitive improvements. To test if CBD causes cognitive improvements in people with schizophrenia, a total of 42 patients, the minimum you need really is 30 for generalizability, with schizophrenia were recruited in a randomized, double-blind, active-controlled, parallel group study. That's probably one of the best studies you can find. CBD CT1, clinicaltrials.gov identifier NCT006289290, that assessed the efficacy of CBD versus amisulpride in improving neurocognitive performance in patients with acute schizophrenia. So I think I can guess where this is going to go. In this trial, patients received either 800 milligrams of oral gelatin capsule of CBD per day. The study was a little small, N is equal to 21, or amisulpride, N is equal to 21. These two were equal, over 2 weeks, using 10 different neurocognitive performance tests. Jeez. Gotta belabor it, huh? Patients receiving oral CBD or amisulpride demonstrated a significant improvement in visual memory, processing speed, visual motor coordination, sustained attention over baseline. So they're probably really good at video games after that, or baseball, or basketball, or pool, or tennis, or table tennis, ameliorating cognitive improvements in patients with schizophrenia. All right, in addition, previous research has demonstrated increased tolerability of CBD compared to amisulpride. Taken together, it is possible that CBD is a better treatment for cognitive impairments associated with schizophrenia than amisulpride. However, it is difficult to interpret the efficacy of CBD and amisulpride based on this trial due to the lack of a placebo group. So there's no placebo group. There's no group that just took a sugar pill, and the small sample size. Okay, why don't you just compare it to other studies where amisulpride and placebo were compared? But then they could say the methodology, we don't know if it was the air at the time of the study, or the COVID, or, whatever was going on during the time. Okay, so now we gotta do another study with a placebo group, but this is very good findings, promising findings. In addition, the 4-week treatment curation is likely too short for the study of a chronic disease like schizophrenia. Thus, while CBD CT1 trial suggests an overall positive effect of CBD on neurocognitive function in those with schizophrenia, the findings need to be confirmed in a larger, more appropriately designed randomized controlled trial of patients with the disorder. Okay, no placebo group. Oh, wow. You did everything right except for the placebo group. Oh, you pesky, pesky people, huh? In addition to the CBD CT1 trial, would it, build me up, just to let me down. Leave us on a cliffhanger. In addition, we've got to come back for a sequel, right? That's the way of the research world. In addition to the CBD CT1 trial, a multi-center, exploratory, prospective, randomized, parallel group, double-blind, placebo-controlled study was performed to assess the efficacy and safety, okay, so this is just about efficacy, of CBD as an adjuvant therapy for psychotic symptoms and cognitive impairments often associated with schizophrenia. So CBD plus something else, plus an antipsychotic, and how safe and efficacious was it? In total, 88 subjects with schizophrenia received either an oral solution of CBD treatment, 1,000 milligrams, or you could just say 1 gram per day, N is equal to 43, or placebo, N is equal to 45, and were assessed at baseline and at 6 weeks. Using the PANSI scale, the PANS, as an appropriate endpoint for psychotic symptoms, patients receiving CBD showed a statistically significant reduction of PANS. That's, once again, statistically significant reduction of psychotic symptoms of schizophrenia compared to the placebo group. Yay, we got a placebo group in this one. Oh my goodness. In addition, while the difference was not statistically significant, patients treated with CBD demonstrated greater cognitive and motor speed performance compared to patients in the placebo group, as measured using the Brief Assessment of Cognition in Schizophrenia, BACS, composite score as a secondary endpoint. Thus, these findings suggest that CBD may be effective in treating psychotic symptoms and cognitive impairments associated with schizophrenia. Furthermore, although some patients in this trial experienced minor adverse effects such as headache, somnolence, which is a sleep condition, sleep disorder, abdominal pain, nausea, and diarrhea, CBD was well tolerated overall. So, like Joe Biden says, you gotta take the good with the bad. Right, Bo? Together, the study confirms the potential efficacy and tolerability of CBD in patients with schizophrenia. The efficacy and safety of low and moderate doses of CBD. Since lower doses of CBD are associated with low or even negligible side effects, 2 clinical studies investigated the efficacy and safety of low and moderate doses of CBD in patients with schizophrenia. The first trial was a 3 parallel arm, double-blind, placebo-controlled study to investigate the effect of CBD on cognitive dysfunction associated with schizophrenia. In this study, patients with schizophrenia, N is equal to 28, received a dose of 300 milligrams, N is equal to 9, or 600 oral gelatin capsule of CBD, N is equal to 9, or placebo, N is equal to 10. Using the Stroop color word test as a primary endpoint for cognitive performance, patients receiving a low or moderate dose of CBD did not demonstrate a significant improvement over placebo. Once again, patients receiving a low or moderate dose of CBD did not demonstrate a significant improvement over the placebo, suggesting that low and moderate doses of CBD are not efficacious in improving cognitive performance in those with schizophrenia. Double or nothing. However, further study is warranted, as the trial was relatively small. While the cognitive impairment associated with schizophrenia was not improved by a low or moderate dose of oral CBD in the previous study, the possibility that moderate oral dose of CBD, i.e. 600 milligrams per day, may reduce positive and negative psychotic symptoms in patients with schizophrenia could not be entirely ruled out. So I'm going to just skip all the way to the bottom here. It seems like it's like 800 milligrams per day for 4 weeks, or 1,500 milligrams per day. Okay? That's pretty much what it's at. All right? So anybody who wants to exit the class after this, you can go. The possibility that moderate, okay, so it can't be ruled out that 600 milligrams does not work, right? Almost a little bit more than half a gram doesn't work. It can't be ruled out that it does not work. Okay, we get it. Thus, a recent study examining the effects of a fixed moderate dose of CBD in the treatment of psychotic symptoms associated with schizophrenia was performed. This randomized, double-blind, placebo-controlled, add-on parallel group study was conducted in 36 patients with schizophrenia. The patients with schizophrenia, they should just say, the best study in the world, instead of saying all that. This randomized, double-blind, placebo-controlled, add-on parallel group study was conducted in 36 patients with schizophrenia. The patients with schizophrenia received either 600 milligrams of oral gelatin capsule CBD, N is equal to 18, or placebo, N is equal to 18, daily for 6 weeks this time, 6 weeks. Using PANSS and Matrix, consecutive cognitive battery, MCCB, to assess patients' reported change in the progression of schizophrenia from baseline, Treatment with 600 milligrams of CBD did not show a beneficial effect on psychotic symptoms and cognitive impairment on the primary outcome, suggesting that this dose of CBD, i.e. 600 milligrams per day, is not effective in the treatment of positive and negative symptoms of schizophrenia. However, CBD was well tolerated with no worsening of mood, movement, psychotic symptoms, or cognitive function. Okay, great. We need the negative findings just as much as we need the positive ones. It's okay. We don't want that file draw problem. Although the reasons for the discrepancy between the aforementioned studies and the other large clinical trials discussed above are unknown, it is likely that the differences may be attributed to the study size and possibly the dose and treatment duration. Okay. For instance, both Boggs et al. And Halak et al. Studies used lower doses of CBD, 600 milligrams per day, and either 300 or 600 milligrams per day, respectively, over a short period of time, 6 weeks, and a single dose, respectively, compared to other large clinical trials. Thus, given the fact that CBD has very low bioavailability due to its extensive first-pass metabolism in the liver, it is possible that the lack of efficacy of the CBD in the treatment of schizophrenia in these studies can be attributed to variability of oral bioavailability of CBD caused by the use of lower doses of CBD. In contrast, the efficacy of CBD reported in larger trials could be related to the longer treatment duration and larger dose used. Are you saying what I think you're saying? Yeah. If you use something longer and you use a bigger dose, it might be the reason why it's working more. If I got that correct. So, where am I? So basically, you can have a relatively higher serum level, blood level of CBD, okay? If you use it longer and you have a higher dose. That's their interpretation. This interpretation of findings suggests that a high oral dose of CBD is required to achieve better outcomes in the treatment of schizophrenia. In support of this, a recent systematic review of CBD dosing in patients with different types of diseases suggests that higher doses of CBD have a tendency to improve therapeutic outcomes compared to lower doses. Importantly, it should be noted that many of the patient-reported outcome measures in the studies discussed are associated with a relatively high degree of variability between patients. Okay, some may benefit, some may not. As a result, it is unclear if the smaller studies, which often use lower doses and shorter periods of study, were sufficiently powered to allow identification of differences across the study group. So that's why you need, 300 people in a study, right? Because then if you find the same thing that you found, the beneficial findings that you found in the other 2 studies that I talked about, 3 studies, then you could say, it's likely to generalize to all people with the similar conditions, schizophrenia or psychosis, right? That means more power. Power in the sense of research. Statistical power. To generalize, to help more people, to have more confidence that it works in more people. The efficacy and safety of CBD in small-scale, open-label studies. Many other small case studies have investigated the efficacy of CBD in the treatment of symptoms associated with schizophrenia. For instance, the first study involved a patient with acute exacerbated schizophrenia treated with 1,500 milligrams of CBD daily over 4 weeks. Notably, the patient showed a significant reduction of BPRs for positive symptoms of schizophrenia over the baseline with no adverse effects. significant reduction of BPRs for positive symptoms of schizophrenia, that's delusions and hallucinations, from baseline, big difference from baseline, much improvement, great improvement, with no adverse effects. The second case study was conducted on a patient who was already resistant to the standard antipsychotic therapies, so treatment resistant to antipsychotic, and was admitted to the hospital after a suicide attempt. While the patient showed a modest response when treated with 500 milligrams of CBD twice daily for 7 weeks, an improvement in PANSS for positive and negative psychotic symptoms of schizophrenia was observed following an increase in CBD to 750 milligrams twice daily for 8 months, suggesting that high dose of CBD and long treatment duration may be required in the management of treatment-resistant schizophrenia. However, though CBD was well tolerated, a mild transient hand tremor was reported. In contrast to the previous study, 40 milligrams per day of CBD, with the dose being increased every 5 days up to 1,280 milligrams over